Hi, this is Dr. Perry Carpenter. I'd like to thank you for taking the time to join me on this week's video. On this week's video, we're continuing with our new series entitled, What's the Point? And we're now in section 2 of this series. In section 2, the title of section 2 is The New QME Conservatism, and this is our third discussion in this section. In our first discussion, we talked about the new QME conservatism with regards to your causation determination, your AOE, COE determination. That was video number 1. In video number 2, we talked about the new QME conservatism with regards to your permanent impairment percentages. And in that discussion, we talked about the new trend toward providing for lower and lower permanent impairment ratings, even 0% permanent impairment ratings, in those cases where either no impairment can be identified, or in the case where even though an impairment can be identified, the examinee presents with no limitations to activities of daily living. We stated that it's okay to provide a permanent impairment rating of 0% whole person in those increasing number of cases wherein that applies, wherein a 0% rating is the most accurate representation of the examinee's true condition. Well, today in video number 3 of this section, I want to talk to you about the new conservative approach to apportionment. A new conservative approach to apportionment, wherein QME doctors are trending toward providing lower and lower percentages of the permanent impairment as being due to the direct result of the industrial injury, and higher percentages of the resulting permanent impairment being due to quote-unquote what are referred to as other factors. And we'll talk more about other factors here as we go. So today I want to talk to you about your apportionment determination. Now, it seems that apportionment is probably the most difficult issue that doctors seem to face in completing their QME examinations. In other words, doctors don't have any difficulty in completing the physical examination section of their reports, or in completing their review of records, or in completing their social history. It's the sections of the report that require deep and sustained concentration and thoughtful consideration that the doctors have the most difficulty with, and apportionment, of course, is one of those sections. So I get calls from doctors all the time, and they ask me, how do I make my apportionment determination? In other words, how do I come up with the percentages, the percentage of the impairment due to the industrial injury and the percentage of the impairment due to other factors? How do I decide? Well, the good news is that it's actually quite easy. In fact, there's an exact science to the apportionment determination. In fact, there's a very, very limited number of scenarios that you're going to encounter over the course of your career. So once you master the finite number of scenarios, you'll have it whipped forever. And I'm going to share with you some material today that will basically cover 90% of the scenarios that you'll ever encounter. There will always be special cases and special circumstances, but those will be more the exception rather than the rule. I want to talk to you today about the bulk of cases that you're going to be evaluating. And I'll just let you know the conclusion of today's discussion and the take-home message, and that is the bulk of cases that you evaluate are going to result in an apportionment determination with very low percentage, or even 0% of the permanent impairment as being due to the industrial injury, and a very high percent, sometimes even 100%, of the permanent impairment as being due to other factors. And I'll show you why that is. But for this stage of today's discussion, I just want you to start getting comfortable with providing for apportionment percentages that reflect the many quote-unquote other factors that examinees have going on. One of our take-home messages today is that examinees have a whole lot of other factors going on. A lot of other factors going on, and I'll show you why that is here in just a minute. So as the body and the bulk of today's discussion is going to revolve around two main ideas. Number one is the mechanism of injury continuum, and number two is the labor codes 4663 and 4664, which govern the apportionment determination. If you understand number one, the mechanism of injury continuum, and then number two, labor codes 4663 and 4664, you'll basically have the apportionment determination whipped. So let's begin by talking about the mechanism of injury continuum. Now, the mechanism of injury continuum is a critical concept, and the mechanism of injury continuum was described and first propounded with the Escobedo case. Now, I have the entire Escobedo case here with me as a reference for today's discussion. Let me just give you a little background about the Escobedo case and how the mechanism of injury continuum derove from the Escobedo case, and how the mechanism of injury continuum is going to be applied to your cases from here on out. Okay? So with the Escobedo case, Miss Escobedo had an industrial injury in 2002. 2002. This is being recorded in 2016, so this decision goes back many, many years, but it's a historic decision that we still rely upon today for important principles. So she suffered an injury to her left knee in 2002. Now, the mechanism of injury to the left knee has been variably described in case documents. Now, I, of course, have never had access to the QME's original report or any of the original medical records related to the Escobedo case, so we don't know the exact mechanism of injury, but it's been referred to variably in case descriptions as involving either a small fall onto the left knee or a slip and trip without a fall, sort of like a slip and stumble, on the left knee, where momentary pressure came down upon the left knee. So those are the two mechanisms of injury that have been described. Okay, a slip and fall or a slip and stumble onto the left knee. So Miss Escobedo was working at a Marshall's retail store when she slipped and fell, or had a slip and stumble, and developed symptoms of her left knee. Okay? Well, very shortly thereafter, like within days, she developed symptoms in her right knee as a compensable consequence of limping around and suffering altered gait mechanics for the left knee. Okay? Well, she eventually had a medial meniscectomy surgical procedure of the left knee. She had conservative treatment only for the right knee. And when the whole treatment was completed and concluded, the qualified medical evaluator opined that Miss Escobedo had resulting disability of both knees. Now, the left knee had had a surgical procedure, a meniscectomy. The right knee had had simply conservative treatment. The QME provided for permanent disability for both knees, and he apportioned 50% of the permanent disability as being due to other factors, with 50% being due to the industrial injury, which involved a slip and fall or a slip and trip. Okay? And the other factors that were involved was moderate to advanced degenerative arthritis of both knees. Now, it's important to know that prior to the industrial injury, Miss Escobedo had no symptoms. She was asymptomatic with both knees. She never had any medical treatment, and she was completely asymptomatic, she said. Now, how many of our examinees tell us this same story? They tell us that they were completely asymptomatic with the shoulder, the lumbar spine, the wrist, cervical spine, etc. And then came along the industrial injury, and therefore it's 100% the industrial injury that's the cause of the resulting impairment. Well, interesting principle is that the QME in this case, in apportioning 50% of the disability due to the pre-existing degenerative arthritis, he invoked the mechanism of injury continuum. And let me read to you from his apportionment conclusion. The QME said, and this is an important concept, if you get this concept regarding the mechanism of injury, you'll have apportionment basically whipped. So the QME said, he said, Miss Escobedo's left knee residuals are directly related to the industrial injury. So that's the discussion regarding the left knee. Okay? He says the applicant then developed right knee problems as a derivative of the left knee and not as a result of any subsequent cumulative trauma. He says, in my opinion, there is a medically reasonable basis for apportionment given the trivial nature of the injury that occurred on October 28, 2002, and this is referring to the left knee injury, and the almost immediate onset of right knee symptoms that occurred shortly after the left knee injury. He says that the applicant has obvious, significant degenerative arthritis in both knees and essentially worked in a fairly congenial environment. Okay? So, key words here in this description. Number one, he described it as a trivial nature of the injury. Number two, he said that right knee symptoms occurred shortly after the left knee injury. In fact, it was within days or even a week. And then finally, he says that she essentially worked in a fairly congenial environment, meaning that in her job duties at Marshall's, she simply had to walk around. So let's think about this. She developed right knee symptoms immediately after the left knee injury. She did nothing more than simply walking around with a slightly altered gait, and the left knee injury he described as trivial. So in arriving at a permanent impairment rating and considering the apportionment, you have to ask yourself, well, with a trivial injury, why would Miss Escobedo be left with permanent impairment? With a trivial injury, wouldn't she simply receive treatment? Wouldn't she simply get well? Wouldn't she simply recover to pre-injury status and go on to resume her pre-injury level of function for activities of daily living? With a trivial mechanism of injury, let's consider a slip and a fall or a slip and a trip, which the doctor described as trivial. Trivial. What does trivial mean? It means basically nothing. Why would Miss Escobedo be left with permanent impairment after treatment and time? Well, the reason is there's other things going on. There's other things contributing to the permanent, in this case, permanent disability. Okay? Why would Miss Escobedo develop symptoms in her right knee very shortly after a trivial injury to the left knee that caused a little bit of gait compensation? Why would she develop symptoms? Are you going to develop symptoms in your knee as a result of gait compensation? Would a 25-year-old person develop symptoms in their right knee as a result of a mild, minimal gait compensation? Don't people have surgical procedures on their extremities all the time and end up wearing a foot brace, an ankle brace, using crutches, and they ambulate solely with their other lower extremity and never go on to develop symptoms in that lower extremity? Doesn't this happen all the time? Okay? Not everyone develops symptoms in the other lower extremity as a result of gait compensation for the injured lower extremity, but you have to ask yourself, why did Miss Escobedo develop immediate onset? The doctor described it, almost immediate onset. The question is, why? The reason is she had some other things, other factors going on, okay? And that was moderate to advanced degenerative arthritis of the knees, okay? So This raises the mechanism of injury continuum. He described this as a trivial injury. And I want you to start classifying your injuries and your mechanism of injury as either mild, moderate, or severe injuries. Now, he used the word trivial, but let's just use the word mild, moderate, and severe mechanisms of injury. And you're going to see that most of the examinees that we see in the QME evaluation have suffered mild or trivial injuries at most. Now, occasionally we're going to see moderate injuries, and less occasionally we're going to see severe injuries, but in the main, most of our examinees are suffering from mild mechanism of injury at most. Well, with a mild mechanism of injury, if that person goes on to suffer permanent impairment after time and treatment, the question becomes, why? Why? Why have they not fully recovered to pre-injury status? And the reason is because they have other factors going on and other factors that are contributing to the resulting permanent impairment. So let's take a look at a graphical representation of the mechanism of injury continuum and make this concept crystal clear from here on out, and crystal clear so that we can use this in our very next apportionment determination. So let's now go to the whiteboard. I'm back with you now, and I hope you can see this. Have the whiteboard up, and this is entitled The Mechanism of Injury Continuum. So what I want you to do is I want you to start classifying your examinee's injuries as either mild, moderate, or severe. This is the continuum, mild, moderate, or severe. Now, with a severe injury, when the examinee gets to the permanent stationary condition and they're found to have permanent impairment, there's a good chance that 100% of the permanent impairment is going to be due to the industrial injury. So with severe injuries at this end of the spectrum, we see that a very high percentage, even 100%, is due to the industrial injury. And a very low percentage, even 0%, is due to other factors. And let me give you an example. Once had an examinee who was electrocuted. He picked up some live wires in his hand. The electricity went up through his arm, it went through his body. It left scars throughout his entire torso, scorched his spinal cord tissue, and eventually he had an amputation of his right arm just at the elbow. Well, he suffered a variety of problems, and when it came time to be permanent and stationary and make the apportionment determination, I opined that because of the severe nature of the electrocution, 100% of his problems were due to the electrocution and 0% were due to other factors. And that makes sense because this represents a severe injury that would cause similar impairment in any other person. Let me give you another example. I had a young man, age 23, who got his lower extremity caught between the blades of a forklift and a loading dock, and he had a crush injury to his distal tibia and fibula. This then required open reduction internal fixation, required the placement of permanent hardware into the ankle, and he was left with a gait disturbance and some loss of range of motion of the ankle. Well, 100% of that permanent impairment is due to the industrial injury, and 0% is due to other factors, because here we have a young man, there is no degenerative arthritis, he has no symptoms with his lower extremities, he suffers a severe mechanism of injury that crushes the bones, he requires the placement of permanent hardware which contribute to the permanent impairment. In other words, in these examples with severe injuries, it's very easy to understand that a large percent, even 100%, of the impairment is due to the injury, and 0% is due to other factors. Okay? Now, on the other end of the spectrum, with mild injuries, some of these non-injury situations that we see, some of these simply repetitive and cumulative trauma injuries that we see, we're going to see the opposite, such that 0% of the permanent impairment is due to the industrial injury, and a very large percent, maybe even 100%, is due to other factors. Other factors, okay? And this is similar to the Escobedo case. Now, with the Escobedo case, the doctor described a trivial mechanism of injury. He described immediate onset of right knee symptoms as a result of minimal gait disturbance and compensation. Now, the Escobedo case was a little different because the QME provided for 50-50, but the difference of the Escobedo case was that Miss Escobedo, she ended up having a surgical procedure for the left knee, and some of her permanent impairment was due to the surgery, and the surgery was a direct result of the industrial injury. So in that case, rather than it being 0-100, the doctor opined for 50-50. And you might say that in that case, the surgical procedure itself represented a mechanism of injury in and of itself. Okay? So on the mild end, we have very low percentage due to the industrial injury, very high percentage due to other factors, and at the other end of the extreme, we have almost all of it due to the industrial injury and 0% due to other factors. Well, as the mechanism of injury moves from mild to moderate, we're going to see that we have a situation where 90-10. 90% is due to other factors, but 10% is due to the industrial injury. Or, as the mechanism of injury becomes more pronounced or more profound, we might see 80-20. Or we might see 70-30. Or we might see 60-40. As the mechanism of injury moves from mild to moderate, we can reasonably say that more and more of the resulting permanent impairment is due to this significant injury event. We may opine that because the mechanism of injury was moderate, that 50% is due to the industrial injury and 50% is due to other factors. Or we may then have 60% due to the industrial injury, 70% due to the industrial injury, 80, 90, and even 100%, whereas over here we had 0%. So here's the take-home message on this. I want you to start classifying your mechanism of injury as either mild, moderate, or severe. In those cases of a severe mechanism of injury, if the examinee is left with permanent impairment, you can reasonably opine that because this injury was so severe, think of a guy falling off a third-story balcony off a scaffold onto his back on the concrete below. Okay, that's a severe mechanism of injury. This guy is going to be left with permanent impairment, and you can reasonably opine that 100% of the permanent impairment is due to this severe injury, and that this injury would cause similar impairment in any other person, regardless of age, regardless of body habitus, regardless of gender, etc., because the injury was so severe. Okay? With mild mechanism of injury, more and more of the permanent impairment is going to be due to other factors, such as in the Escobedo case, where at the permanent and stationary date, the effects of the industrial injury have long since resolved, but the examinee is simply left with the other factors contributing largely, if not completely, if not 100%, to the resulting permanent impairment. Okay? So you can use this mechanism of injury. Let's now consider the next piece of the apportionment puzzle as relates to Labor Codes 4663 and 4664, and that'll pretty much put a cherry on top and a bow tie around your apportionment determinations. Okay, so that's the mechanism of injury continuum. Now, when it comes time to provide your apportionment determination, if you have a case that involves a minimal mechanism of injury, and that person is left with some permanent impairment, and you provide for a high percentage of the permanent impairment as being due to this minimal mechanism of injury, you're going to have some explaining to do because it just does not make intuitive sense, okay? And you're going to be questioned on that apportionment determination. On the other hand, if you have an examinee who has a severe mechanism of injury and you provide for a high percentage of the permanent impairment as being due to other factors, then again, you're going to have some explaining to do because it simply does not make intuitive sense. So it's the middle of that spectrum, of that bell-shaped curve, where most of your apportionment determinations will lie. Now, my opinion is that we're going to see that the bell-shaped curve is going to have a left-sided skew to it. I should go this way. Left-sided skew, such that more and more of your cases are going to involve permanent impairment percentages that reflect a higher and higher number of the impairment being due to other factors. And let's talk about that now. Okay? Now, our reference for this discussion comes from Labor Codes 4663 and 4664. So let me just read those to you. This is 4663. Apportionment of permanent disability shall be based on causation. A physician shall make an apportionment determination by finding what approximate percentage of the permanent disability was caused by the direct result of the injury, and what approximate percentage was caused by other factors, both before and subsequent to the industrial injury, including prior industrial injuries. Including prior industrial injuries. Isn't that interesting that this language, including prior industrial injuries, was added to this new code section, which was enacted April 19, 2004 with the passage of Senate Bill 899. They included that new language, including prior industrial injuries. Why would they do that? Why would they include that specific language? The reason is because so many examinees come back with subsequent and new claims for industrial injury. In other words, there's a population of examinees who are multiple claimants. They come back with injury after injury after injury. And so the letter of the law, Labor Code 4663, includes those prior industrial injuries as one of the other factors that we can consider in arriving at our apportionment determination. Now, a couple things before we move on. 4663 says that we're required to come up with approximate percentages. So it's important that you realize that these percentages cannot be exact. There's no way humanly possible, medically probable to come up with exact percentages. And the legislature considered that by allowing us to provide for approximate percentages. So when you provide your opinion on permanent impairment, employ the phrase approximate, but provide an exact number. Okay? So for example, you might say, in my opinion, within reasonable medical probability, approximately 35% of the permanent impairment is due to the industrial injury, and approximately 65% is due to other factors. In other words, we phrase our exact numbers in terms of approximations. Okay, so that's how to do that. Now, Labor Code 4664 tells us our instruction, and this is so fascinating. It says that the employer shall only be liable for the percentage of permanent disability directly caused by the injury arising out of and incurring in the course of employment. Well, who's responsible for the remainder of the permanent disability due to other factors? Well, that's the applicant. Okay? So the employer has the burden to demonstrate the percentage of permanent impairment due to other factors. The applicant has the burden of demonstrating the permanent impairment that's due directly to the industrial injury. So those are opposing parties who are going to want to get clear descriptions from us as qualified medical evaluators as to the percentage due to the injury and the percentage due to other factors. Now listen to this. This is section B of 4664. It says, if the applicant has received a prior award of permanent disability, it shall be conclusively presumed that the prior permanent disability exists at the time of any subsequent industrial injury. This presumption is a presumption affecting the burden of proof. And this handles those examinees who are multiple and repeat claimants. How many examinees do you see that have a prior award of permanent disability? It's a large percentage of the cases that you see, correct? Correct? Why is that? Because we have a population of examinees who are repeat claimants. Okay? So the law tells us that if the examinee has received a prior award of permanent disability, then that permanent disability exists and persists into perpetuity, till the cows come home, till death do us part, to forever and beyond. What that means is that at the time the examinee suffers the subsequent injury, the second injury, they already had a bad back. They already had a bad shoulder. They already had a psych injury. They already had a gait disturbance, or whatever their prior permanent disability was. It exists and persists forever. Now, remember that Senate Bill 899 was emergency legislation designed to handle the skyrocketing workers' compensation costs, and this is one of the skyrocketing costs that existed. Examinees with prior awards claiming that they had completely rehabilitated themselves by the time of the subsequent injury, and that the permanent impairment due to the subsequent injury is entirely new. But the law offset that by saying, no, if you had a prior permanent disability, it exists forever. And if you have a subsequent industrial injury, you're only compensated for the worsening. Because according to the law, by the time you had the subsequent injury, you were already bad. You were already permanently disabled to a certain percentage. So that percentage gets apportioned right off the top, thereby reducing the percentage of permanent impairment directly due to the industrial injury. Can you see that with the mechanism of injury continuum and with Labor Code 4664 and its requirement as to how we handle prior permanent disability awards, we're now providing for permanent impairment percentages due to the industrial injury that are lower and lower and lower because the mechanism of injury does not justify a high percentage and because many examinees already have a large percentage of their permanent impairment being due to other factors. In this case, the other factor that we're talking about is a prior award of permanent disability. Well, what are some other factors that contribute to our apportionment determination for other factors? Well, it's interesting. The law does not limit the number of things that we can consider in arriving at our apportionment determination due to other factors. There's no limit to the things that can contribute to the permanent disability. So let me ask you this. When it comes time to provide for your apportionment determination, what consideration do you give to the healing benefit of time? What consideration do you give to the healing benefit of medical treatment? What consideration do you give to the healing benefit of total temporary disability? In other words, removing an examinee from the injurious environment. What consideration do you give to the healing benefit of generous work restrictions that limit the examinee's exposure to injurious motions, circumstances, environments, etc.? In other words, if you have an examinee who's off work on total temporary disability and is receiving quality medical care from skilled and professional providers, what consideration do you give to the healing benefit of that time and the healing benefit of that treatment? You know, it's interesting. Many times I talk to doctors and I ask them this, and I ask them, well, the examinees received medical treatment now for the last 6 months, correct? The doctor will say yes, and I'll say, well, why aren't they getting well? And the doctor will say, well, they've been getting crappy care. They've been getting crappy care. And I look at the medical records and it says that they're getting treatment from Kaiser, or they're getting treatment from a chiropractor, or they're getting treatment from an industrial medicine clinic. And I ask the doctor, well, what's crappy about the care that's rendered at Kaiser? What's crappy about the care that's rendered by Dr. Jones Chiropractor? What's crappy about the care rendered by San Joaquin Occupational Clinic? We have to assume that the medical care that's being rendered out there is quality care, is excellent care, is caring care, that it's being delivered by competent, credentialed professionals trained in their specialties. We have to assume that all medical care is being rendered by caring people who have a sincere interest in seeing their patients get well. And so I'll ask doctors, well, when you treat your patients, don't your patients get well? And the doctor will always assure me, well, yeah, my patients get well because I'm a fabulous doctor. I mean, my patients tell me that they've never ever had a doctor such as me, and that they were instantly cured under the touch of my hands. And I remind these doctors that, you know what? The doctors in these other clinics, such as at Kaiser, other chiropractors, other physical therapy places, they have patients that come to them with the same miraculous healing stories. You're not the only excellent doctor. The medical care that's being rendered to examinees, we have to assume is excellent, quality, professional care delivered by sincere professionals who sincerely want to see their patients succeed and get well. So when an examinee does not get well and results in a permanent impairment rating, right? Anyone that ends up with a permanent impairment rating is an examinee who's failed medical treatment. They failed to recover to pre-injury status. The question becomes, why? Why? Why have they not fully recovered? And the answer to that question is because they have other factors going on. In the absence of other factors that complicate their recovery, most, if not 100% of examinees are going to fully recover from the effects of the industrial injury, except for those that are involved in the most severe mechanisms of injury. So if you have an examinee who's had adequate medical treatment, adequate opportunity to recover to pre-injury status, and yet they fail to recover, the question becomes, why? And the answer is, they have other factors contributing to the permanent impairment, and you can confidently and reasonably apportion those other factors out and provide for a very low percentage of the permanent impairment being due to the industrial injury and a very high percentage of the permanent impairment being due to other factors. Okay? So doctors, I hope this helps you. A couple of key points here, and that is the mechanism of injury tells us everything. Only in the most severe mechanism of injury are we going to see people that fail to fully recover to pre-injury status. In the examples that I gave you, that my examinee will never have his arm back. Okay, the other examinee will never have the hardware removed from his distal tibia and fibula. These are severe mechanisms of injury. We expect these people to have resulting permanent impairment. And in these cases, a high percentage of the permanent impairment is due to the injury, and no other factors are involved. But that applies only to the most severe cases, the severest injuries. Most injuries are either mild or moderate, and people recover from those. In our clinical practice, don't we expect these people to recover? We do, and they do. If they fail to recover, it's because there's other factors contributing to the permanent impairment, and those other factors need to be apportioned out in your apportionment determination. So doctors, this reflects a new conservative approach to the apportionment determination, and in my opinion, it's an accurate approach. It's an approach that you can reasonably support by way of supplemental report or by way of deposition, should the case come to that. And this is an approach that really makes sense. It just makes sense. And that's one thing you have to always ask yourself with your apportionment determination is, do these numbers, do they make sense? If they don't even make sense to you, or if you cannot even defend those, then you need to rework your approximate percentages around to some percentages that make more sense. First of all, and even to you. Okay? So doctors, I hope this helps you. This concludes our second section of our new series entitled What's the Point? In section 1, we talked about the new QME conservatism with regards to AOE-COE. Part 2, we talked about the new conservatism with regards to your permanent impairment determination. And in this section, we talked about the new conservatism with regards to your apportionment determination. It's my opinion that we're overinflating the apportionment percentage due to the industrial injury, and we're understating the percentage due to other factors. Many examinees have a whole lot of other factors, including a lack of motivation to fully recover to pre-injury status. They have a whole lot of other factors going on, and we simply apportion those out to come up with numbers that are accurate and make sense. So it's been my pleasure to be with you here. Next week we're going to start section 3 of our new series entitled What's the Point? So I look forward to being with you next week. For now, I want to thank you for taking the time to join me on this week's video, and I'm wishing you best of success in your career as a qualified medical evaluator.